Thank you everyone for joining us today for this webinar. It's part of our Dr. Richard N. Merkin Distinguished Speakers Series. The webinar is hosted by the Schaeffer Center for Health Policy and Economics, the Price School of Public Policy, and the USC School of Pharmacy. And my name is Dana Goldman, and I'm the director of the Schaeffer Center and also the interim dean in our School of Public Policy. And we're very grateful to Dr. Merkin for sponsoring this series. His philanthropic leadership and commitment to improving healthcare helps us bring these prominent policymakers, experts, and industry leaders to discuss some of the most pressing problems in healthcare facing the United States. And in that regard, I'm really pleased to introduce our three panelists today, and of course, the topic we're discussing. We're going to be hearing from Vassilios Papadopoulos. He's the dean of the USC School of Pharmacy. He spearheaded USC School of Pharmacy's ongoing efforts to distribute the COVID-19 vaccine at both Lincoln Park and Dodger Stadium. You might have seen his crew on the Ellen DeGeneres show. Before joining USC, he served as executive director and chief scientific officer of the Research Institute of McGill University Health Center in Montreal. He's an elected foreign member of the National Academies of Medicine and Pharmacy in France. He's a fellow of the American Association for the Advancement of Science and a fellow of the Canadian Academy of Health Sciences. We also have Dr. Neeraj Sood. He is a professor and vice dean for research and faculty affairs at the USC Price School of Public Policy. He's director of the COVID initiative at the USC Schaeffer Center. His research focuses on economic epidemiology, infectious disease, health insurance, economics of innovation, and global health. And he's currently leading a study on COVID-19 in collaboration with the Los Angeles County Department of Public Health, with the mayor's office, and I believe with the fire department in Los Angeles. And then our third participant is Dr. Lina Nguyen. She's an emergency physician and public health professor at George Washington University. She's a non-resident senior fellow at the Brookings Institution. She's also a contributing columnist for the Washington Post and an on-air commentator for CNN as a medical analyst. And I might point out she's the best thing about CNN. So I hate to extemporize an introduction, but let me start with you, Dr. Nguyen, because you served as Baltimore's health commissioner. And so you have been on the front lines in distributing vaccines. Where are we in the state of the pandemic and from your vantage point?
Well, first of all, it's great to be with you today, Dana, and great to join this really incredible panel that I'm looking forward to learning from. Where we are in the pandemic, I think, is a place that we don't know, as in we're at a crossroads of sorts. On the one hand, we do have vaccinations being ramped up. We have the summer weather or warmer weather coming. We have seen a very steep decline following the huge surge over the holidays. But on the other hand, we're also seeing states really remove restrictions, including in many states, mask mandates. And we also have these variants coming that may well be more contagious and in fact may evade the evade the protection that the vaccines are providing in some way. And so I think that we're at this tenuous place. It's anyone's guess as to where we're going. I do think that as it applies to vaccinations and to the vaccine rollout, again, there's kind of good news and bad news. The good news, so if we think about the process of getting vaccines into arms, there are three major barriers. There is supplies, there is administration, and there is acceptance. President Biden just announced this week that by the end of May, we should have the supply issue sorted out so that there'll be enough supply for every adult American to receive a vaccine. That's fantastic. And now we have 3 authorized, highly effective and safe vaccines. That's great. we have a long way to go when it comes to administration of the vaccine and access to the vaccine. And I actually think that right now, so much of what's happened is we are attributing lack of access, in particular in minority communities, to hesitancy, when actually the problem is access. But then there's the third part that we have to work on, which is that of vaccine acceptance at some point. At some point, probably that'll come in the late spring, early summer, we are going to have enough supply. We are going to have enough distribution sites. And the major issue is going to be convincing people to take the vaccine. And I actually think in this case, and I hope we have a chance to talk more about this later, Dana, is I think we have not been doing a very good job of messaging why this vaccine is so important. Yes, it's about protecting others around you, but also I think there's a lot of people want to take the vaccine because we want to resume our lives. We want to see our loved ones. We want to do the things that we haven't been able to do in the pandemic. And I think we need to do a much better job of explaining what are those freedoms that we can regain once people get vaccinated.
Neeraj, Dr. Nguyen just made the point that we are in a race in a way. We're trying to get shots into people's arms, but we have variants emerging and we're relaxing restrictions, which is something I'd like to come back to. But you were early on, back last March, I believe you wrote a piece in the Wall Street Journal where you argued we're never going to quite get a handle on what's the appropriate policy response unless we know about information about prevalence and incidence and complications. Where do you see where we are now based on what you've been doing?
Thank you, Dana, and thank you for giving me the opportunity to be part of this panel. I think there are kind of two issues. I think a lot of our policy has kind of made perfect the enemy of the good. So early on, the WHO came up with a COVID test, which several countries around the world adopted, but the US was slow to adopt it because they wanted to come up with their own tests. And as a result of that, we lost precious time. And by the time we started testing in the US, we'd kind of missed the boat. There was already community spread, and test and treat kind of became, testing and contact tracing became a less effective strategy. The second thing is we haven't focused a lot on really measuring how well we are doing against the disease. So for example, several countries across the world have done large population representative seroprevalence surveys to figure out how many people have been infected, how close are we to herd immunity. When you implement a policy such as a mask mandate or safer at home policies, what does that actually do to the dynamics of the disease? And we know this disease has a huge asymptomatic population. So just testing symptomatic individuals is not going to give us the answer. So we've been relying on these convenience testing, which is whoever wants to show up for testing, we'll test them and then we'll track those cases over time. That doesn't really give us an accurate picture of what's happening. So right now there are a lot of modeling studies and some, seroprevalence studies, which say that maybe, 30 to 50% of the US population might have had COVID. If you combine that with vaccinations, it says we are fast approaching herd immunity. We might be there in a month or 2 months. But if you really want to know the answer to this, we should have done this large-scale seroprevalence study to figure out this answer. And right now, we're kind of relying on some old surveys and modeling to figure out this answer. And I think in the current thing, we're again kind of making the same mistake we made early in the pandemic, which is making perfect the enemy of the good. So right now, we're sticking with the strategy that everyone has to get 2 shots within the 3-week period as we tested them in the clinical trials. And I think that's a mistake. I think we should follow UK strategy, which is let's get the first dose to everyone. And then when we have increased supply, get the second dose to everyone. I think the marginal impact of vaccinating someone who hasn't been vaccinated is much higher than giving a booster dose to someone.
Well, we'll want to come back to that. Thank you. That's another controversial area that I'd like to get a reaction from the panelists. But before we do that, Dean Papadopoulos, you, as I said, have been out there distributing vaccine. You've seen how different states have done it. What is your assessment of where we are today and what we can do better?
Thank you, Dana. Thank you, the panelists and the attendees, for really being here to talk about this problem, which may not be a problem. So I'm optimistic. So as you may know, already in the United States, 53 million people have been already vaccinated, at least one dose, and half of them 2 doses. I mean, this is already, 20% of the population. We are far away from where we have to be. And also that the vaccination rate is now 2 million doses per day. So at this rate, by the summer, everybody should be vaccinated. So this is the good news. Now, the world is not perfect. Not every state responds the same way. The distribution is not done in, the same way everywhere. We're dealing with a global problem that I believe, however, the solution is more at the community level. So it is very difficult to generalize what happened in other countries, what happened in the US, and what happened in California, and the same thing happened in Montana. So looking at the statistics and the numbers, we see that some states like West Virginia, Alaska, and some others have done extremely well in terms of vaccination rates. But there are specific cases. West Virginia used the community pharmacy very rapidly. Because they know the communities, people trust the pharmacists, and they really know what's happening. They know the families, they know everybody. And this takes away also some of this hesitancy issue. Alaska is different. They are remote communities. When an aeroplane lands somewhere in Alaska with vaccines, they vaccinate the whole village because it costs a lot of money to send a second flight. So 2 different examples. On the other hand, also talking about Los Angeles itself is bigger than some countries around the world. So comparing with other countries is very difficult. You have a very large, diverse population. So I know that faculty and staff and students and alumni of our school run here pods or hubs of vaccination, and there are lines. Sometimes we have to shut them down because not enough vaccine. So this is a limitation. So people want to be vaccinated. For sure, some they don't, but the numbers are increasing because also we see that people are not getting sick. Yes, for a day or 2, there is any vaccine. Shingles vaccine is painful, any vaccine. But even water you inject, 20% of people have pain. So in reality, I think the supply is improving, and this will be the solution. And then we should really look for community level responses of how to distribute. And again, I believe pharmacy, which is 66,000 pharmacists around the United States, could be an amazing way to do that. And already they do it. Some states and the government now is pushing the pharmacy into a community pharmacy into the forefront for vaccination and also to address hesitancy issues.
Thank you. So both you and Dr. Nguyen have emphasized that supply may no longer be as much of an issue, and it's really about distribution. Neeraj has made a very provocative point that I'd like to come back to you, Dr. Nguyen, about, which is that, maybe we should be following the UK strategy of 1 dose. And maybe supply will figure it out for itself, but maybe it would allow us to get back to return to normal more quickly. Did you want to comment on that?
I do. So I first want to say that in general, I agree with Neeraj very much on this idea that perfect cannot be the enemy of the good. In fact, I use the statement a lot because I think so often that perfect solution stops us from doing something right now. And it's extremely frustrating to me as an ER doc. I mean, I'm all about let's take action, let's do what we can now and do as much as we can, even if we don't have that perfect solution. And in fact, this is why I think along the lines of what I was saying earlier, for letting people return back to normal, normal, even if we don't have perfect data on, as an example, is it 100% safe to be visiting your grandkids? I think a lot of grandparents want to be doing that now. Even if we don't have perfect data, we can give that kind of advice. That said, I actually really strongly disagree with the idea of the one-dose regimen. And here's why. We are not the UK when it comes to attitudes about the vaccine. I was on a really interesting webinar yesterday with an individual who is a practitioner in the UK. And he was talking about how through the National Health Service, people are just so excited to get something. They really trust the National Health Service. The acceptance of the vaccine there is 80%. 80% of people say, right now, I will get whatever dose is available to me. Whatever you have available, I'm going to get that. That is not our issue here in the US. There is a strong anti-science contingent, number one. Number two, there are a lot of people who are hesitant of these vaccines because they think that it was developed too quickly. Then there are all these people who are distrustful of government, distrustful of doctors for understandable reasons and for not understandable reasons. But there are a whole bunch of reasons as to why that's the case. So my point here is that our limitation to why we do not achieve herd immunity, and I think there is a very real chance that in the US, we will never get to herd immunity. Our major barrier is not supply. Supply is the major barrier right now, I take your point, but our major barrier over time is acceptance of the vaccine. Anything we can do now that would erode trust in the vaccine and in vaccine development now is going to hurt us so much later that I don't want to solve for a problem that's right now when the knock-on effects we're going to see much later. And by the way, we haven't even talked about other potential effects as well, as in Dr. Fauci and others have, for example, made comments about, might we have more variants arising if people are just taking one dose of the vaccine? Are we going to have a lot of people who take one dose but not the second dose because they don't think it's important anymore? What about, I worry about this as a clinician, what about people who take the first dose but then get ill because they don't have necessarily that good protection? They spread the word about how these vaccines don't work, and it further deters others from getting that other vaccine, from getting more vaccines in the future. One other note here is the number one thing that I see in my patients as the reason why they will not get the vaccine now is they say, I worry about speed, that things were developed too quickly, that expediency rather than science was the reason why we have these vaccines so quickly. My reaction is, no, we are prioritizing safety. We're prioritizing the science. If we now go back on that and say, actually, we want to get more people vaccinated, so we want to give first doses to everyone, I really worry about what that does for us longer term. That said, I agree with you about perfect not being the enemy of the good.
Neeraj, you're welcome to comment on that, but would you like to comment on that?
I still think that giving the first dose, like right now, the problem is that demand exceeds supply. So for example, in LA, there are several vaccination sites that say second dose only because we don't have enough supply. So we are actually prioritizing second doses over first doses. And I have just in my peer group, several people trying to figure out like, how can I get this vaccine? And they cannot get the vaccine because we are prioritizing second doses. So, and I think, the science, there's nothing in the science which says that you need to get the second dose after 21 days. You get the second dose on 40th day. Yes, we don't have the clinical trial evidence to show that, yes, 40th day will not work the same as 21st day. But if you talk to any card-carrying virologist or immunologist, they'll say it should have the same effect. So again, like we're being, in some sense, too narrow in our thinking, focusing on one clinical trial rather than using our scientific judgment to look at the big picture. The big picture is, if you give a dose to one person, that gives much more immunity, that brings us closer to herd immunity than giving that marginal dose to someone who's already been vaccinated.
I think that's true, but I do want to emphasize something Lina said, which is that there is this broader issue, which is mistrust of science. And if you start to go outside the lines of what the public health evidence has done, then people may use that, especially if it turns out that it's not as effective, then you can breed distrust that could have a permanent effect on public health issues. I see you nodding and waving. So, Vasily, did you want to weigh in on this?
Yes, actually, I will not really change any FDA recommendation. Really, it's very important. The trust is a major issue. And also, already, Neeraj, sometimes people, they show 3 days, a week later, it's already happening. And it's not a problem, most likely, but I will not do that. Remember, these vaccines, the history, the science behind, everybody thinks is yesterday. The one is already 30-year story, and the other is 15 years ago. And they were already developed for flu. I mean, already the engine was there. So we have to make sure we follow the trials, we follow the results, because to extend what Dr. Nguyen just said, most likely all of us, we need a boost vaccination once per year, like the flu. Whether it's identical or addressing variants, most likely this will happen. And we better have complete confidence in the FDA recommendations rather than changing things to really facilitate or address a problem we have today. Concerning the supply, we should really, I know there is a crisis. I don't think there's a crisis. Things are happening very well. Remember, this is the first time in the history, to my knowledge, that industries start making vaccine before approval. Any drug you do, you make some lots after approval, and then you do post-marketing and you do surveillance. Here, the first millions were made before even we know if the vaccine will be approved, which was, so now they accelerate, and this you see the news more, the agreements between companies have to facilitate, make more plants, more manufacturing is happening, because even the first post-marketing surveys on people vaccinated show no side effects. So this is a further reinforcement that it works and it is safe. And this happened every day. Every day, people vaccinated, that they fill up the form. What happened to you between now and then? All this is collected. This is the post-marketing surveillance that normally takes years. It is happening live for millions of people in the United States and around the world. And every day passes, we are more sure that the vaccine will have no side effects. So, and I think this also now accelerates manufacturing. The possibilities are there to really go faster. So I think I would stick to FDA recommendations. And now the issue, however, to address it is how we manage to vaccinate people in the middle of nowhere, as I say, miles away from downtown LA, in California, or in remote areas, and people that essentially are minorities, who there is some historic challenges of mistrust of the government. I mean, let's be honest. So these are the issues I see more important to solve as soon as we can.
Okay, so I want to come back to that issue in particular, because Dr. Nguyen made the point that we, in this country, we have a lot more distrust potentially. We have a lot more skepticism. Some of the questions coming through on the Q&A are related to that, and I want to encourage people to submit their questions there, and I will titrate them appropriately. But I think one of the issues is that other countries and states even that have had very simple policies, for example, you're over age 65, you can get a shot, have had success in getting vaccines more quickly. And again, this is the perfect being the enemy of the good. A lot of people have been concerned about equity, and California just announced that they're only going to reserve the next 2 weeks of supply for certain communities that have been hardest hit. And I want to ask whether a sophisticated policy that tries to meet all objectives is the enemy of the perfect, using Neeraj's theme, the perfect is the enemy of the good. Would any of you like to take that on?
I can try a little bit. So again, as I said earlier, I think we are dealing with a global problem, but the solution should be at the local level, at the community level, because not every community is the same. So, and again, take as an example, Los Angeles, and again, the Podge work, Dodger Stadium is fantastic, 12,000 vaccinations, but some people, they have no cars. How do they get there? Talking about the reservation through the internet. What about if you don't have internet? if you don't have a computer, how, all these things, how we address these problems. And to me, the solution to that, it is always to go to the community. Now, again, with the 2 vaccines, 2 shots is always a problem, people coming back, reservations. And this is where the power of the J&J vaccine with a single shot is like flu. You can have mobile clinics like we do for the flu every month of October. Our school goes with the city and other organizations goes around the area and we vaccinate thousands of people. This is a big advantage, but I think we have to really work with the local factors, the communities to address these issues.
I think, Dana, what I would say is, whenever you impose some rules or hurdles for access to vaccines or access to health or anything, who can figure out how to break the rules? It's the well-off people, it's the more educated people. They can figure out how to navigate that system. So in that sense, I agree with you that we want like simple access, which is a simple rule. Anyone above 65 for the first 30 days, you can get vaccinated. And we have to kind of, as Vassilios was saying, take the vaccinations, forget this online appointments, send mobile vans to communities, go outside a church, go inside those communities, work with the pharmacists, and vaccinate as many people as we can. I think these rules make it too complicated. And then it breeds this vaccine hesitancy that, oh, I'm not supposed to get it now, I'm supposed to get it later, and so on.
Lina, did you want to comment?
I do. I mean, I think this is a really complicated issue. I do agree that the simpler you make the operational logistics, the more likely you are going to be successful. We saw what happened in the beginning when we had the 1A group that was so narrow that you ended up having millions of doses sitting around in freezers because people who were initially supposed to be allocated those doses weren't getting them. I mean, that's not good. Having wastage, having time that could be better spent actually getting the shots into arms. I certainly agree. It's important for us to actually get the work done. That said, if you open up eligibility too widely, you have a problem of a scarce resource and a free-for-all. And we know what happens in a free-for-all, which is that people who have resources, people who have the means are going to find a way to access that very scarce resource. And so it's a balance. I also just want to say that the other countries, including the UK, as was mentioned, they did have a system that was simple in the sense that they said it's only age-based. And I can understand, again, the benefit of something like that. It is simpler, but also the other benefit is that if the goal in society is to reduce illness, hospitalization, and death, then you really just want to focus on older individuals and then move your way down age-wise, because that's the simplest way. Instead of saying, here are the list of medical conditions and obesity and smoking are on this and people start getting upset, just say that it's only about age. I understand that. On the other hand, though, if your goal is to keep the economy operating, and recognizing that there are people who don't have the privilege of physical distancing, you have a different set of priorities. And I think that we in this country, we're trying to do two things. And me personally, I actually think that we should have done a lot more with prioritizing essential workers. That includes, as both of the other panelists mentioned, reaching people where they are. I think you can, for example, go to a meatpacking plant and vaccinate everybody in the meatpacking plant, or go to a jail and vaccinate everybody in that jail, or go to a school. I mean, there are settings that people are at. Why are you making these people take time off from work to go to a mass vaccination site? That makes no sense. But I do think that the idea of not just doing age, but also focusing on essential workers is a different question, and actually an important one that illustrates societal priorities too.
To add one thing, Leana, so you said something that this is how they address issues in developing countries with a crisis that they needed immediate vaccination. They went locally to schools, to villages, to areas, and they vaccinated everybody. Now, again, in the United States, you cannot do that easily, say we vaccinate everybody, because for various reasons, people may not want to do it. But this is how it was done in many developing countries for the last 50 years, at least. This is how it's done.
So I want to ask all of you, one of the arguments against this kind of all out, well, let's take what Neeraj said, which is put the vaccine in vans and go to the communities. The states have claimed poverty for doing this. Now, as part of this, one of the stimulus bills, we've already put trillions of dollars into the economy as a result of this. In California alone, fraud on the unemployment benefits has cost the state $31 billion by some estimates. It's not 31 billion. If you had bought vans to distribute this, you could have gone to every community you wanted to and done individualized shots for probably less than that. So I don't really think this is about money. I think this is about willingness to just be bold and to do these things. Could any of you comment on that?
So Dana, I was on a similar panel last week, and one of the other panelists kind of brought up this interesting anecdote. So he works in Africa. And he was like, I'm working in this village in Africa. There is a shop that sells beer and soda. And then there is the public health clinic, or the primary care clinic. The beer shop is always stocked. There's always beer available. There's always soda available. But the public health clinic doesn't have bandages, doesn't have medicines. Why is that the case? So it seems the beer truck can come to the village, but the medicine truck cannot come to the village. And I think that's the case is because of incentives, right? The shopkeeper has the incentive to keep the beer there. The doctor in that public health clinic still gets paid whether or not there is medicine in the clinic. And we need to, I think, capitalize. I think we need to work with the private sector, and we need to capitalize on these incentives. If we incentivize people to bring vaccines to communities that need them, they will bring them there. And they will have the expertise to deliver that. And I think we are not thinking broadly about public-private partnerships to make that happen. We're kind of doing everything too centralized, too much within the government. Like public health departments are not logistics companies. They don't know how to deliver vaccines to millions of people. So I think we need to capitalize both on incentives as well as expertise outside the government to make it happen.
So it sounds like there's a theme emerging, and I'll come back to that about this heterogeneity across communities. The dean talked about the way you would distribute in Alaska is very different than downtown LA, and that could we provide better incentives for distributing vaccines? And I want to come back to some of those in a second, but did anyone want to, did you have a comment on that, Vassilios?
Many times the question comes back to the having a healthcare system or many. The US, we like our choice and we love it. And for sure, we like to have options about healthcare system. It comes with many advantages. In a time of crisis comes with the disadvantage that you have all these players and they don't play together. So again, but I compare also with the European system, and I can take France, Germany, Greece. They all have healthcare system. In the terms of vaccination, they are failing completely. So it looks like there is no perfect world there. However, in times of crisis, you always would like to see it is whether it is at the state level or the federal level, a leadership to provide, to bring what Neeraj said, these public-private partnerships to take care of the problem that a 350 million people country with almost unlimited resources somehow is struggling. So, and I think this is what we missed somewhere, with all these political issues, everything else, we missed this kind of leadership to really solve a problem that the vaccines are there, the money is there. As you said, buying the trucks is a problem. Come on. I mean, everything is there. You can really parachute the vaccines, honestly. I don't think just the will lost between the micropolitics of our today's 2021 United States.
Lina, did you want to comment on that? Yeah, I mean, I first want to say I agree with what Neeraj and Vassilios said. I wanted to add something a bit provocative, perhaps, to this conversation, which is, look, I think that what the Biden administration is doing when it comes to prioritizing equity is really exceptional. I mean, I have not seen really any administration focus on equity as an endpoint as well as a metric of success. I mean, that's really important. That's not the provocative part. I haven't gotten there yet. Here's the provocative part. I think that the Biden administration is confusing equity with somehow saying that equity means that you cannot have competition. And they're basically saying we're going to have lowest common denominator. And what I mean specifically here is I think it's really important for us to hold people accountable and hold entities accountable. If you're giving, let's say, 10 pharmacies and community health centers in a particular area 100 doses of the vaccine, I want to see where are all these doses going? How quickly are they getting distributed? I want that competition. I want that public accountability, because let's say that one pharmacy is able to get out all 100 doses on the first day. They are just so desperate for additional doses and they know they can get it out. The community really trusts them. They're really efficient. But there's another pharmacy that maybe they're not advertising that they have vaccines. Maybe they have a really backwards registration system. Maybe they only have one person working there 5 hours a day and they're not able to get out the vaccines. Why don't we know this? Why can't we then say this pharmacy that's not doing very well, if they're not doing well, give their allocation to the pharmacy that's really doing well? You can actually.
Lina, I just want to say, we think of Neeraj as an economic epidemiologist. You now are a physician economist for that. So welcome to the club. We're super impressed by that. Vasily, did you want to comment on that?
And to support what Lina's saying, California, they have really used 76% of the allocated doses. There is some states that are 90%. Why this gap?
Yeah.
Talking about this percentage, the gap of 14% between the two, it is millions of people to be vaccinated. And again, I'm not accusing, I'm not criticizing. I don't know the details sometimes, just I see the statistics and the numbers as published across all the states in the United States.
Okay,
but see, one of the reasons why that's the case is they're saving them for the second doses, which makes me upset. I want to get those doses out right now. I don't want to wait a month to get those doses out.
Fortunately, this has been recorded so that Neeraj will not need to repeat that again. But you have gone on record as advocating for that. we're gonna note that. I want to switch gears a little bit, because one of the, and this is a question that Irv Steinberg put in the chat, and I think it's a very interesting one, which is there was a lot of distrust of the pharmaceutical industry prior to COVID. In fact, some people had ranked them as badly as politicians and tobacco companies. And actually, trust in pharmaceutical companies has risen quite a bit as a result of the pandemic and the contributions they've made to public health, which are very clear. On the other hand, I want to come back to something you said, Lina, which is the United States is different than other countries in terms of its trust. And we often say it's trust. You mentioned the NHS in the UK. We think of it as trust in the health system and government. Is there something to this mistrust in the United States of the pharmaceutical industry that is driving potential vaccine resistance?
It's a good question. I'm curious what Neeraj and Vassilios may have to say about this too. I mean, I think that it's important for us to disaggregate the reasons for vaccine hesitancy. There are some individuals who are truly anti-vaccine, as in they don't give their children vaccinations, or they may be truly against the pharmaceutical industry and refuse to take anything from any product from the pharmaceutical industry. I don't think that that's the vast majority of people who have some concerns about the vaccine. I think people have the vaccine for a lot of them for legitimate reasons, as in they just don't know enough. And I think it's important for us to approach them with listening, compassion, empathy. I mean, I can't tell you the number of patients I've talked to who have some, for example, misunderstanding. They might say, I don't want to get coronavirus from the coronavirus vaccine. Well, there's an easy answer. This does not contain a live virus. And so it's important for us to convey that. And so I'm maybe not so concerned about this distrust of big pharma, distrust of the system as much, because I think a lot of the vaccine hesitancy that we can overcome are in the people who just have a concern that we can address pretty easily. And I think also by tying that to a return to normality is going to be really important for convincing people who are otherwise on the edge.
Okay.
So there's a recent Kaiser Family Foundation survey where they've been tracking vaccine hesitancy. And the big reason people don't want to take the vaccine is one of the reasons that Lina talked about, which is they don't trust, they think the vaccine came out too quickly and the safety hasn't been evaluated. And the second is just concern about safety, that they think this vaccine might not be safe. And I think both those reasons play to what, Dana, you're talking about, that one of the reasons this comes up is because they think pharmaceutical firms are greedy and they can manipulate the system and actually get a vaccine out that's not safe because they see there's a lot of money to be made there. So I think some of that, even though the survey doesn't address that directly, I think some of that might be playing into this. And I also agree with Lina that we are way underselling the vaccine. So, if you like, this vaccine produces such a strong response, but if you say, no, but you're still susceptible to the disease, there is then why am I getting it? Oh, you can still infect others, then why am I getting the vaccine? So we're magnifying those messages rather than saying that this is an awesome vaccine. It's a slam dunk. Everyone should get it.
But there is an issue. I think the reason they do that is because doesn't mean the moment we are vaccinated, the masks go away, the parties start, everybody goes out, like until we really follow and we see the whole, the environment is freed of the COVID, which may never happen. Flu is always comes back, and there could be like many other viruses, so that every year we'll need another boost of vaccination. So to me, actually, the industry, I have to say what Dr. Steinberg says, right? We mix the quality of the vaccine with the drug pricing. We mix the pharmaceutical industry, we put all together like in a big soup. However, we live longer thanks to medications, quality of life and medications. Many diseases have become chronic diseases thanks to drugs. So, and again, the industry people, there's always bad apples, like in any industry. But in this case, some of the companies did not even receive money, federal support for the vaccines. Not everybody received billions.
I want to come back to the controversial remarks that Dr. Nguyen started with. She didn't mention Governor Abbott in Texas, who just lifted the restrictions and the mask order. And one of the questions from Jeffrey Joyce is that the CDC has already estimated that maybe 100 million people in the US have been infected. We've got 40 million people who've had maybe a single dose. It is possible, and I'd like to hear from all of you, that we're approaching herd immunity and we've been locked in our houses. Humans are social. So is it time to open up? And what is the evidence on that? And what is the right policy to do here? And who wants to start? I'm not gonna make Lina start first. Neeraj, you've been working on this. Why don't you start?
So I agree with Jeff that my reading of the evidence is at least 100 million people have had COVID and have some immunity as a result of it. I think according to the latest numbers, about 70 million people have been vaccinated, and a lot of the elderly have been vaccinated where the mortality risk is the highest. So I think we are approaching herd immunity. The other thing is, if you look at the evidence on what do safer at home orders do, or what does kind of shutting down the economy do, there are papers which show that safer at home orders do reduce the number of COVID cases. But if you look at the evidence on whether safer at home orders reduce excess mortality, which is in some sense what we should care about, does it save lives? I don't think there is evidence which shows that it saves lives. That doesn't mean it might not, but the scientific evidence doesn't exist right now. So we know, shutting down the economy has consequences, not only on economic outcomes, but on health outcomes. It affects mental health, it affects anxiety. If you don't make enough money, it affects your access to healthcare and so on. So I think it's a tough choice. And I think we are approaching herd immunity, and I would be in favor of, reopening the economy.
Lina, Barbara Turner points out something you did as well. We've got these new variants. Is Neeraj right, or?
I think it's important for us to be humble in this. I mean, I don't think that Neeraj is right, but I don't know that I'm right. And so here's why I'm not convinced about the fact that I'm not at all convinced that we have reached any level of herd immunity. We have 8% of the population that's fully vaccinated in the US. We have the highest estimates that I would trust in terms of people who have been infected before and therefore have some level of immunity is about 33%, let's say. So you add that together, we're nowhere near the 70 to 85% that's really needed for herd immunity. That said, do I think that the vaccinations that we've done thus far have done a lot of good? Absolutely. We have seen that in the nursing home data, as Neeraj very well pointed out, that the percentage of deaths and infections in nursing home residents has really dropped precipitously. I think that we should be considering herd immunity on a micro level going forward, as in there may be communities that have reached herd immunity. So for example, if everybody in a nursing home has gotten immunized, there probably is some level of community immunity in that population. And in the same way, as we start seeing more in the population become immunized, you may have enough immunity protection over members of a school community, for example. Even if children are not vaccinated, if all the teachers and parents are vaccinated, you may have a herd immunity effect in that way. But do I think that it's time for us to loosen restrictions and go back to normal? Not at all. I am very concerned about what's happening in Texas and Mississippi and other places that are reopening completely, and critically that are removing mask mandates. I understand, by the way, the economic argument for reopening. I fully understand that and can appreciate it, and then think that it's a difficult way, right? It's Neeraj, I think, mentioned very well. There are real consequences to keeping the economy closed and keeping kids out of school. I really get that. So you can make the argument that we should be reopening. But if that's the case, keep the mask mandate, as in that is a very small price to pay in order for the economy to be open, in order for businesses to come back, in order for kids to be back in in-person instruction. And so I think we need to disaggregate this and maybe talk about masking in a different way than we talk about reopening certain businesses.
So once again, you've earned your economic credential. I'll come to you in a second. You've earned your economic credential again. And Vasily, go ahead.
No, just some statistics. Today we are 2 million doses per day. And even if we stay like that, let's say, the estimate is 50% of the population will be vaccinated by June 16, 70% by August 16, and 90% by October 16. So the herd immunity, there is many, many numbers, but average consider 70% of the population. Some say 90, some say 50. But this is the numbers. Now, if vaccination is improving, there's more vaccines, these numbers and these dates could really shift to earlier times. So we have paid a big price with the deaths and the people in hospitals for 3 months to change what is working in terms of masks, in terms of precautions, in terms of everything else. And we should not forget one thing that somehow nobody ever mentions. This year, we didn't have any flu problems, thanks to the masks. A side effect, a positive side effect that we should really also think, because also a number of people die from flu. And this year, this somehow disappeared because everybody was following distancing and masking. But I considering the dates I gave you, this, by the way, is not mine, CDC. You can find on the web. So if we accelerate the vaccination and hopefully hesitancy becomes less of an issue, I think in 3 months we should be really everybody vaccinated, and then we can really relieve the pressure of distancing and other things. Today, not yet.
We had decreased transportation, and some of us got a refund from our auto insurance companies. We have deferred health care, which Neeraj has pointed out and written about, which is means we should be getting rebate checks from health insurers. So actually, this has been a very interesting and helpful discussion. I want to ask all of you a policy question, and Neeraj, I know you have another comment as well, which is, if health equity is an important goal, losing a year of education is particularly dangerous, especially for the most vulnerable kids. So would all of you support a go back to school mandate with masking, mandatory masks, universally except in hotspots around the country? Anyone want to?
Dana, there is a reason why most countries have universal education, right? Because it is probably the most important intervention to lift people out of poverty, to improve their health. And as you said, like, keeping kids out of school has the most worst effect on children from lower socioeconomic families. And here the science is pretty clear that schools are not a source of transmission, but we still have kept the schools closed. So I'm all in favor for reopening schools.
I'm sorry that I'm not. But I
you
like
do not have to apologize, because you're an official card-carrying economist.
But I think this is so fascinating to me, because so often I feel like I'm part of conversations where everybody is like, yes, I agree, me too, and this is why. And so I like that we have a lot that we agree with, but a lot of nuances, should we say, in issues where we may not always agree. Look, I will just tell you my own background in this sense, that I used to oversee school health in the city of Baltimore, overseeing school health for our 180 schools. My mother was a school teacher in Los Angeles at LA Unified. She taught second grade in East LA. The students that I served in Baltimore, 83% on reduced or free lunch. I mean, I very much understand, and Neeraj, very much appreciate the point that you raised about how our most vulnerable children are being left behind. And it really is a very significant tragedy that schools have been closed and have not been prioritized in the way that they should have been. I just wrote an op-ed, and I will send this around to everybody on the call with my views about school, because I think that if we have the debate about schools being safe or not safe, we are never going to agree. Because there are some people who will say, as Neeraj said, again, rightfully so, schools are not super spreaders. Children tend to not get very sick. Also, we know that in many cases, the risk of acquiring COVID-19 in schools is much lower than acquiring in other parts of the community. So let's bring it back. Other people are going to say, but I am isolating at home. Surely you cannot tell me that being at home by myself is the same risk as being in school with a bunch of other people. There is not zero risk. And I think we need to move away from this conversation of risk and actually talk about, are schools essential? And I think for many people, in-person schooling is absolutely essential. For some people, it's not. And I think allowing for that nuance is really important. But I do agree that come the fall, getting every school open at 100% capacity, meaning Monday through Friday, full time, should be our top priority. I don't think we should mandate that every student is back and every teacher is back, but I do think that every school open at 100% capacity is necessary. In order to do that, we also have to be vaccinating all adults involved in those cases. And I think that is something that I'm not sure that we as a society are going to be ready to do.
Vasily?
Again, I will side with Leana on that. And the reason, to me, it is what happens when 5 kids in one school are hospitalized, and you have really some of them, young kids, problems with the syndrome, really immune reaction, very, very strong. What happens with that? What happens the next day? Do you shut down again schools? Sometimes it's worse to open and then go back and close them than keep it as it goes. To me, all our efforts should go, instead to have 70% vaccinated everybody by August, we should have 90% of the people vaccinated by August and go back in the fall. So rather than take any risk, and if you see, at least I follow LA County daily updates, you have every day 20,000 kids infected. So, and do you like to open and close them? I would prefer to really push the vaccination, make sure this is happening across across the United States. as fast, as soon, as safe as possible, and take care of the problem.
I think
I heard schools open in, sorry, I'm going to summarize though. I heard schools open in the fall for sure, and communities get to distribute vaccines in a way that's appropriate for them. And if people do a good job, they should be rewarded with more vaccine. Is that okay. Neeraj, go ahead.
So I was just going to say that, there is this kind of thing that if we keep schools shut, that's the safer thing to do. Or if we keep the economy shut, that's the safer thing to do. And I don't think it's a safer thing to do, because keeping schools shut has real harm on children. And so, just saying that, we don't know what's going to happen, so let's keep it shut. Let's wait for 3 months. Well, in 3 months, many more kids are going to get depressed. Many more kids are going to try to commit suicide. Many more kids are trying to use drugs. Many more kids are going to go into gangs. So it is not a question of this is the safer thing to do. I agree with Leana that I don't know whether my opinion is better than hers, that, it is debatable whether reopening schools is more dangerous than keeping schools shut. But both are dangerous options. There's danger on both sides. So we cannot say this is the safer thing to do and just stick with that. We really need to look at long-term consequences of the policies we're taking.
Well, okay. It turns out I know the right answer, but we're out of time. So we'll have to wait for the next. But I will say, we are in a laboratory with all the different state policies. So I think everyone knows we don't really know the answer right now, but we will hopefully learn from this as we go forward, as we've learned. I want to thank all three of you for a really vigorous discussion and debate. You've all been very thoughtful about this and have been contributing to the policy debate, and we're quite proud to be affiliated with all of you in various ways at the Schaeffer Center. So thank you to the audience for listening, and thank you to the three of you for taking time, and everyone take care out there.